I'm the president-elect of the European Society of Intensive Care Medicine, so I am very happy that you are taking this course and this program to help in an intensive care unit. My talk will focus on the basics of a clinical examination to have an approach to recognize a sick patient and to do simple actions to stabilize this patient and then to bring this patient, if needed, to the intensive care unit. And what I will describe as parts of a clinical examination and the ABCDE approach, it's something that should give you a method, and it's a method that we use every day, not just to look at patients outside of intensive care unit, but to have a method to really reassess clinically every time there is a need. So what is really important is to understand that the physiology of the patient is becoming deranged and recognizing these signs. Probably another important point is also to understand when we need to ask for help. Intensive care is a multidisciplinary specialty. There could be colleagues that have more experience and some less experience. Sometimes it's really just good to get to see a patient together and then to understand if we need to escalate the level of care. Ganesh already referred to this. A timely assessment and recognition of a sick patient and timely introduction of actions to try and stop and reverse this process are really key. And really, time is probably one of the most important things that we've learned over the decades of intensive care practice into really to try to stop the development of shock, multi-organ failure, and ultimately death. I will refer a little bit also to shock. We have several definitions of shock that you can find. The first from Harry Weil, one of the fathers really of intensive care, which is a reduction of effective blood flow and inadequate tissue perfusion with a decreased delivery of oxygen to the capillary exchange bed. We recently redefined this in not changing it completely, but basically saying we define it as a circulatory shock as a life-threatening generalized form of acute circulatory failure associated with inadequate oxygen utilization by the cells. And even if we don't talk about circulatory shock, and in the specific of this course, we are referring to patients with respiratory failure, it's very important that the balance between the delivery of oxygen, the utilization of oxygen by the cells, and also the removal of carbon dioxide is really key in any process that could lead to critical illness and to intensive care admission. So if we do one step back, really, how do we deliver oxygen and clear carbon dioxide in our body? And I would say that I like to remember from physiology, and every time I see a patient, I like to remind myself of the fine mechanisms that we have in terms of compensation from the respiratory system, the cardiovascular system, and the renal system. Of course, it's much more complex than that, but the beauty of these three systems that they continuously work as a mechanism to try to keep the balance of our life is that they give us also a window to assess whether there are some signs that there are the interactions between these systems, and they are giving us a window to understand that there is something going on and maybe that the patient is deteriorating. So we will talk significantly about the respiratory system and the cardiovascular system. The renal system is always also working there. It's a bit more complex to understand what happens in terms of electrolyte. So the urine output is really our window there. Still important, but we will see that just by having this in mind, we can get a good gut feeling, a good understanding of what's happening with our patients. So what is the formula of the oxygen delivery? If we remind ourselves, is the combination between the cardiac output times the oxygen content. And what is in the square brackets here is the oxygen content. This part of oxygen content is the oxygen that is directly solved into the blood, not connected to hemoglobin. It's a minimal contribution, and for simplicity, we can actually take it away for the moment and just focus on the other components. So hemoglobin and oxygen saturation are clearly very important, especially when we looked at respiratory failure. Hypoxemia will lead to a lower oxygen saturation, and ultimately respiratory problems and anemia will lead to lower hemoglobin, are really something that could profoundly impact the oxygen content. This is one of the reasons for which we give oxygen, to try to restore the oxygen saturation and the moles of oxygen that are directly connected to saturated hemoglobin. But cardiac output is a very important variable in this equation because it is one of the variables that probably can be manipulated and can change the most. Because for the saturation, even if we give oxygen, even if we reach 100%, we cannot go any higher than that. And for hemoglobin, we know that we cannot overtransfuse our patients. So when there is a situation in which there is a higher need for oxygen, really the change in cardiac output is probably one of the most important keys to compensate in situations where there is an increased need for oxygen consumption. To remind everyone, cardiac output is also depending on other variables. We can simplify this by considering the heart rate and the stroke volume, and the stroke volume depends on the preload, the contractility, and afterload. We will come back to this later. What is the problem with an inadequate delivery of oxygen, with an inadequate utilization of oxygen by the cells? Well, for instance, we can look at efficiency of energy production. If I have an adequate oxygen availability at cellular level, I will produce a much larger moles of ATP compared to when I have dysoxia. And in those cellular beds, actually, it becomes more difficult to produce ATPs for the same quantity of glucose. What does the body do in that situation? The body is looking for fast fuel that can be used even without oxygen. Indeed, lactate, in this sense, is the solution that the body tries to bring to be able to cope with this increased requirement for energy. That's an important concept. A high lactate that we will find in our blood gas is not the problem, is the reason for which, is one of the solutions actually for which the body is producing this lactate, and we have to go and find back what is the reason for it. This way of producing energy also lead to an increase in hydrogenous and also in carbon dioxide. So why is this important with respect to our clinical examination? Because very often this will lead to a decreased pH and to the need to also to clear more carbon dioxide. What is one of the most common signs that we will find in this situation with our clinical examination? An increasing respiratory rate, because the body tries to increase the minute volume ventilation to clear carbon dioxide. And again, we can look at this. Also, the heart rate may increase because the body is trying to bring more oxygen to the tissues. We can see what happens. Often blood pressure is kept at very steady levels, and it's only at late stages that we can see the blood pressure dropping because the compensatory mechanisms are going down. The respiratory rate is usually a very early sign. And if we look at what happens with urine output in situations like this, often the kidney is trying to preserve intrathoracic blood volume so the urine output can actually drop. So just by looking at these variables, we can get a sense that maybe something is going on in the periphery. I'm often asked when it comes to this about the fact, is it more important to look at blood pressure? Is it more important to look at blood gas with lactate and understand if there is a problem with oxygen utilizations in the periphery? I would say that we cannot really work in compartmentalized ways when we looked at single variables. It's important to take all these variables together. This is an old study now, but I think it's a very nice study that looked at the interaction between these different components. As you see here, the mortality goes up not only when the blood pressure is low in sick patients or when the lactate is high in sick patients, but it goes up not just by addition, but in a synergic way when we have patients that are both hypotensive and with high lactate. And at the same time, what you can see here is that I could have patients with a normal blood pressure, with a systolic maybe of more than 90, which I could consider to be normal or not a worry. But if a patient has a high lactate above 4, these patients are already affected by significant mortality. And I can see the same thing for patients with normal lactate, but vasoplegia, so with low blood pressure again. So very important to look not just at one variable, but to try to put all the things together. How do we approach a patient with our clinical examination? Well, traditionally, we had an approach to look at the history of the patient, examination, think about the differentials and so on. I'm not saying that this is a bad approach, but it's a very time-consuming approach, and often in situations where we're called to see a deteriorating patient, we have to be a little bit faster. So the ABCDE approach is what we are going to focus over the next few minutes, and it's basically looking at airway, breathing, circulation, disability due to neurological deterioration, and the exposure of the patient. And it's something that we can really do, reassess, and continuously do. And it is something that allows us not only to assess, but to do interventions and to see if the interventions actually can change what we see in front of us. It shouldn't take more than 5 minutes. And what are the key components of this? Let's look at airway and oxygenation. Very importantly, just by the way we approach the patient. Can the patient talk? A patient that is talking to us is giving us already a lot of important information. Does the patient sound distressed? Short sentences, maybe they are a sign of a high respiratory rate. Same thing going to breathing and ventilation, especially for patients with respiratory failure. This is really key. As we were saying before, for several reasons, the respiratory rate is one of the variables that is the most sensitive in changes when there is a clinical deterioration. It's normally kept between 12 and 20. A very low respiratory rate usually is related to drug usage like opioids or to neurological conditions. A high respiratory rate, and for high I mean something above 20, usually is a very important sign for the recognition of a sick patient. There are plenty of studies that show that, for instance, when we are looking at predictions of patients that go into cardiac arrest or that have important physiological derangement, we can see that in the clinical notes, very often respiratory rates start to go higher hours before this deterioration. Particularly when we have patients with pneumonias, we have to remember that the situation is very complex because there could be a cause within the lungs, which is the pneumonia itself. And at the same time, the lungs becomes a way to compensate for this clinical deterioration. So the respiratory rate is a very, very important variable to measure. We will also go on with our examination looking at other basic but important signs. Is the chest clear? Is the ventilation bilateral and equal? Are the signs of cyanosis? And looking at something that we can measure very easily now, like oxygen saturation. If it is above 94%, I should also ask myself on how much oxygen. And if it is below 94%, usually it's good practice to give oxygen to stabilize the situation when we assess and we see how the patient reacts to this. When we go to circulation and to the management of shock or simply assessing the circulation, again, very simple variables that we can look, like the heart rate. May be good to ask or to find out what is the normal heart rate for the patient. Same thing for blood pressure. Remember, mammals and the humans have evolved in a way that blood pressure is normally kept at the expenses of many other variables. So usually when the blood pressure is low, it should always be considered a clinical emergency, something that we need to find out why the compensatory mechanisms are not working anymore there. If we know more about the patient, and maybe we find out that the patient normally runs on a lower blood pressure, that's something we can think later. But at the beginning, a low blood pressure is also a very important sign of a patient that is already very sick. Something that we can do just by using our hands, we can feel the temperature of the limbs and see if there is a gradient, for instance, by touching the fingers, the hands, the elbows, and from the feet and so on, and going more centrally. Capillary refill time, something that we can measure and we can quantify. Usually the capillary refill time, if the circulation is adequate, is less than 2 seconds. A capillary refill time that is extended is suggesting that there is a problem with the capillary bed of those patients. I will show you some images about this very soon. And again, we can carry on with listening to the heart and looking at heart sounds and so on. But what I was telling you before about the compensatory mechanism, also looking at variables like the urine output is telling us potentially some other mechanism of compensation there. And I want to see also if there are signs of edema. So the peripheral perfusion, which is something that I can do with my clinical examination, probably is a good window for something more complex to see. And we definitely are not going to look with microscopes during a clinical examination, but just to give you an idea, when I look at the capillary refill time, when I feel the temperature of my patient, I could see basically and assess what is the microcirculation. A good microcirculation would have a good vessel density, there will be good blood flow, the red blood cells will flow And you can imagine that they can bring oxygen, remove carbon dioxide in a very efficient way. When there is a poor microcirculation, and we know that in the infection that leads to sepsis and deranged physiology, there is a very heterogeneous capillary bed in our body, and that could lead to poor microcirculation where the capillary density can be different. And you could imagine that here, the transport of oxygen, removal of carbon dioxide could be much more complicated. If I have a patient that is, in my opinion, in front of me, dehydrated and hypotensive, what I can do is, for instance, challenge the circulation by giving a very small bolus of fluid. Remember that just because the patient comes with respiratory failure is not a contraindication to give fluids. Indeed, very often patients that maybe waited long at home before coming to the hospital may have been too sick to eat and to get dehydrated, and that could come to our attention being hypoxic, but at the same time also being dehydrated. And I don't have to wait for blood pressure to go low. I could still, with my examination, find out that maybe this patient could benefit from some fluids. A way to assess this while doing my examination could be to give a small bolus of maybe 250 ml of fluids over 15 minutes. The idea is to increase the intravascular volume and to see if I see improvement in variables such as heart rate, arterial pressure, and so on. Moving to the last part of our examination. D stays mnemonically for disability due to neurological examination. There are different scales that we can use. Something very easy to remember, however, I find is the AVPU scale. A is the patient awake. V, does the patient respond to verbal stimulus? P is for pain, does the patient respond to painful stimulus? And U is the patient completely unresponsive. This is something that we can do also in our intensive care unit. What you see here on the right side is a patient that is intubated. We have ways to sedate patients now, and when they recover from the very first phase where we have to take full control of their breathing with our machine, we can support them and they can work with us, and they can be sedated in a way that can still interact with the environment in a comfortable way. Coming to the end of the examination, E stays for full exposure. This is the moment where I've done the other basics really to explore whether I've missed anything else. So I will do a full exposure and I will try to get some extra information. If I've not done it before, I will try to see what happens also in the drug chart and so on. This is a table that you can look to, and it's a summary of what we said so far. By having this method, it really becomes easier to remember a lot of these things, and then we can think about actions and maybe additional steps that we want to use to assess and to stabilize our patient. If we think that the patient requires admission to the intensive care, I can carry on reassessing and see if my stabilization can get some extra time to understand what I'm going to do. And an important thing to add probably on all of this, I would say if I have to add one exam on top of my clinical examination, I would definitely say on top of saturations and so on that are available everywhere, I would say an arterial gas is something that gives us a lot of information to understand where the patient is compensating. To communicate the situation with other colleagues, a way to do it in a very methodical way and to have a very clear communication could be the SBAR tool. The SBAR tool stays for situation, background, assessment, and recommendations. And this is something that both who is calling or who is speaking on the phone and the receiving end can use to make sure that the information is precise, simple, short, and to the point, and that everyone is understanding what the plan is going to be. Coming to the end of my talk, if we have assessed our patient and the patient is not improving, or if we think that the patient requires the attention to be admitted to an intensive care unit, this is the time where we will bring the patient to the ICU, and probably we shouldn't lose a lot of time. However, it's important to remember that just an examination that tells us that the patient is not doing well should not be enough to decide whether the patient should come to the intensive care or not. It's a complex decision. It's something that probably is better done with a team of people. But when we decide to admit a patient to the intensive care unit, we should also try to understand some of the history of this patient and understand if this patient has a good chance of coming to the intensive care unit, receiving organ support, and making a recovery to be able to leave the intensive care and hopefully to leave the hospital. Just to conclude, Holding hands and smiling behind the mask is something we've all done a lot during this crisis. It does not make it to the ABCD list, but they are highly recommended. And it's a good way really to be working in our teams, to be doing the best for our patients, also in terms of keeping a very human touch to what we do every day. So my conclusions are that the clinical examination really always comes first, even for an environment which is so filled with technology like intensive care. It's important to choose a routine method to reassess daily and every time we need. Important to integrate basic variables is really the key, and we have so much information that we should not miss. I talked about the respiratory rate just to give a few, but there are others. Mental state also very important. And if I have to add something, I would say an arterial blood gas, and today we didn't have the time to talk about this, but I would say more and more basic echocardiography and ultrasound is probably, they are skills that can help us a lot to get some differential diagnosis or to understand a bit more about the patient in front of us. Thank you.
Thank you very much, Maurizio. It's a very nice presentation. You've also very nicely made the point, which I think we all have in common, which is that this is about basic clinical skills and applying them in any area of the hospital. So although we have higher technology interventions and monitoring, which has its place, actually this sort of thinking is accessible to anyone in any area and is obviously most important to the patient wherever they are. You very nicely made the point that this is about taking a combined approach to all the different indicators that we have, rather than compartmentalizing or taking things in isolation. So which makes this a slightly unfair question, but in your 5-minute examination as an experienced clinician, if you walk up to a patient and they are on the cusp of decompensating, what would you sort of prioritize as the 1 or 2 key things that would really ring alarm bells for you and tell you that they may be just on the verge of losing compensation?
To be honest, the beauty of this approach, I would say it's something that you can do very fast. So even if, the ABCD, it's a way to explain it, but actually at the same time, when you see a lot of these patients, you can still do A, B, C, and D together. So, very often, if we go to a patient that is going to decompensate, and I think I'm very close to the compensation, even if I'm an experienced clinician, I would tell you probably one of my first actions would be go to the patient, at the same time ask for some help. It's good to be in the situation, maybe with somebody else. And if I'm not as experienced, even more, I would like to have someone that has a bit more experience than me. And when I go there, really oxygen, thinking about IV access, it's amazing what some oxygen and IV access and having some drugs ready to support maybe the blood pressure in a short period of time, they can give you those extra 15, 20 minutes where you can get the grips with the rest and do other important interventions that often are very simple. And if I get that, it's much easier also to get the situation ready if I really want to escalate much more the organ support, deciding for intubation and so on.
Okay, no, thank you. That's a very simple and strong point, actually. So this is about parallel processing of all those parameters, and it can be done very quickly and together. And you make a very good point about rapid escalation and getting help, which I think is sort of key to acute healthcare, isn't it? The second question is, so I think we've all learnt that at the heart of good care for COVID-19 is delivery of good acute care and critical care, and rather than necessarily lots of too specific things. But just in the context of your talk, is there anything sort of specific to COVID-19 that you think is worth highlighting in terms of interpretation of signs?
I would say is a lot of these patients, as you probably have seen, they come with severe hypoxia. But actually, if you look at their blood gas analysis, for instance, often the carbon dioxide levels are very normal. So it's an hypoxia which is not accompanied by problems with carbon dioxide clearance. So very often these patients, we found them that they were with very low saturation. They were breathing maybe a bit more, but they did seem quite comfortable. And I think it's very important not to be fooled by the fact that the carbon dioxide is under control, with the fact that maybe this patient, they really need a bit of help. A sign for me that was very important to decide I'm not happy to keep this patient just with some oxygen is if the patient gives you any signs that is becoming a bit tired. This is a very important sign, not to let the patient becoming tired. This is a patient that even if he's compensating with normal oxygen saturation with giving oxygen. Maybe it's a patient that I want to monitor a bit more closely. And if I have the feeling that the patient is becoming tired, I need to think early about extra support, whether this is just CPAP or whether I don't need to lose more time and intubate maybe this patient and put everything at rest for a few days.
Okay. Thank you. Again, very clear. And thank you for your final, or one of your closing points was around the appropriateness of decision-making and committing patients to this process. And that ties in very nicely to Professor Endicott's talk. So we'll look forward to that. And at the very end, you very rightly emphasized that the human side of ITU is the key to all of this. So thank you for that as well. Thank you for your presentation.
Thank you, Ganesh.
Okay, thank you.